Good morning, good afternoon, good evening, everyone, and welcome to our webinar today. This is a joint effort of the International Diabetes Federation and World Obesity Federation to celebrate the launch of our joint policy brief, Obesity and Type 2 Diabetes, a joint approach to halt the rise. I'm Johanna Ralston, I'm CEO of the World Obesity Federation, and it is my great pleasure to be here along with my colleague, Professor Akhtar Hussain. Professor Hussain?
Yes, good morning, good evening, good day, and wherever you are most welcome to join this seminar. As you understand that this is a very important meeting in order to put a focus on obesity and diabetes, which is an integral part because obesity is most often present in the case of diabetes and is one of the main cause, a causal relationship with diabetes. So therefore, it is very important for us, and the report the joint report that we are producing at this moment, a policy brief, will also be very important for you to see. I'm Professor Akhtar Hussain. I'm a professor of diabetes and metabolic disorder at the Nord University in Norway, and I'm also the president-elect of the International Diabetes Federation. Today, we will have 4 panelists to talk to you. Will share their perspectives and expertise on obesity and type 2 diabetes prevention. Before we start, we would like to inform you that the webinar will be recorded, so you will also have the possibilities to see the recorded webinar later. Attendees can use the question and answer session function to post questions if you have any. The recording slides and the feedback questions will be circulated by email in a few days' time. To address the obesity and type 2 diabetes, that we know that obesity is a chronic metabolic disorder that affects all adults and children equally all over the world. Obesity is known one of the main risk factors for a number of NCDs and diabetes in particular. The term diabetes is also known for this reason. To start with, I will say that halt diabetes, halt NCDs, halt obesities to halt diabetes. Thank you.
Thanks so much. So again, before we start speaking about the policy brief itself, and again, we do ask you to please download that. We want to talk a little bit about the broader context of non-communicable diseases. Unfortunately, the NCD burden is at an all-time high. NCDs are responsible for 41 million deaths annually, which is 71% of global deaths. Diabetes and obesity play a significant role in those numbers of deaths, and many of which are premature and in low and middle income countries. To address this, a decade ago, WHO set voluntary targets as part of its global action plan to help reduce the global burden of NCDs. The overarching goal of these targets is to achieve a 25% reduction in overall mortality from the 4 main NCDs, diabetes, cancer, cardiovascular, and chronic respiratory, which was to 2025. Now, many of the targets have been extended to 2030. The joint diabetes and obesity target, again adopted in 2013, was to have a 0 increase in the prevalence of diabetes and obesity by 2025 based on 2010 numbers. We're going to hear from Akhtar a little bit now on how we're doing with that in diabetes, and then I'll speak to obesity.
Thank you, Johanna. That despite these global targets that you have just mentioned, the situation has not improved in the last decade. It is actually deteriorating. We see this kind of rising prevalence, as you see these 2 maps here, that one on the right featured the estimates of diabetes prevalence. To date, there is a continued global increase in type 2 diabetes prevalence, which accounts for about 90% of diabetes cases. As you know, that at the moment that we have about 537 million people have diabetes, with a death of 6.7 million deaths related to diabetes. And this estimate is feared to rise to 724 million by 2045. given these estimates that we know that there are uncertainties because there will be, it is, for example, COVID-19 alone, that how much it is going to impact the rise of the diabetes, we still don't know. So the global epidemic is, epidemic of obesity is also increasing faster than we fear or we projected for. And therefore, this number that we are talking about, 724 million, probably is going to be, is by far a low estimate. I would like to mention that the World Economic Forum has just talked about the diabetes as a silent global epidemic, which is 3 times as deadly as COVID. But we are not afraid of diabetes or obesity, but we are afraid of COVID. So I will ask to hear a little more from Johanna.
Great, thank you. So the map on the left shows the adult. Could we go to the previous slide again? The estimates of obesity prevalence in adults, and again, obesity defined as BMI equal to or greater than 30. Are essentially that these targets, the zero prevalence target is seriously off target. All countries are off track to meet the zero increase in obesity prevalence by 2025. And I would add that World Obesity Federation published an updated atlas for World Obesity Day, which is now 2.5 weeks ago, showing that in fact, prevalence, number of people living with diabetes is projected over that time period of 2010 to 2030 to actually double. So we're seeing 100% increase in obesity from a zero increase target, which tells us that there's much more than this an oversimplified narrative driving this. The global rise in obesity and type 2 diabetes can be attributed to multifactorial changes in the economy, demography, epidemiology, dietary habits, and physical activity patterns. If we're to halt the rising prevalence of obesity and type 2 diabetes, we need to address these various root causes. Simplifying these diseases to any one cause makes prevention, treatment, and management efforts more challenging. It's vital that we recognize that multiple facets working together is key. And that's why we have developed this joint policy brief on obesity and type 2 diabetes. Next slide, please.
As you can see that IDF and WOF have developed this policy brief for diabetes and obesity advocates, healthcare professionals, policymakers to provide recommendations on the actions required to prevent, manage, and treat both obesity and type 2 diabetes effectively. The policy brief emphasizes that we only be able to halt the rising incidence or prevalence of type 2 diabetes if action on obesity is also prioritized, provides a background about the root cause of obesity, and recognize that it is a risk factor for type 2 diabetes and other health conditions, requiring urgent action, both in short and long term. Highlights the importance of adopting a system-wide approach if we are successful to halt the rise of incidence and prevalence of diet-related non-communicable diseases, and advocates for people-centered care and ensuring that the people living with obesity and type 2 diabetes and other non-communicable diseases are included in the development and evaluation of interventions and guidelines. Johanna?
Next slide, please. So now we are going to move to our panelists and hear from esteemed panelists on various elements of the diabetes and obesity challenge. And then we will have opportunities for questions and answers. I do want to acknowledge an extraordinary mix of participants on this. It's very encouraging and inspiring. And we ask you to really sharpen your thinking, ask the difficult questions. Please post them in the Q&A box. Our first panelist, next slide please, is Professor Mike Lean, who is Professor of Human Nutrition in the Glasgow University. Professor Lean will be speaking about the global landscape of obesity and type 2 diabetes. Professor Lean.
Thank you very much, Joanna. And this is a great privilege to be able to contribute to this policy brief. Can I have the next slide, please? I'm a physician diabetologist working in Scotland, but also have a public health role. These figures I've taken from the policy brief, and they just show, you'll see many versions of the different colors, show the distribution, firstly on the left of obesity, measured as a body mass index over 30, and on the right of of diabetes, which is principally type 2 diabetes. And the match between the development of obesity and type 2 diabetes in different countries is an extraordinary succession. So as populations become overweight and then obese, sure after that comes type 2 diabetes in its wake. And we've learned over recent years that obesity is not just a body mass index over 30 or over any number. It's not just a big waist circumference. It's a disease process. And that disease process has a genetic, important genetic contribution, and of course also major environmental interaction with the genes which we inherit. And the disease process of excess body fat accumulation has many, many different consequences. Type 2 diabetes follows this and is part of that disease process. We now understand that type 2 diabetes is recognized with an elevated blood glucose or hemoglobin A1C. It has complex metabolic origin, which involves both a resistance to insulin, tissue resistance to the work of insulin, to allow us to use the glucose which is circulating in the blood, and also a failing insulin production from the pancreas. And these two components cause the blood glucose to rise and the glucose to be inaccessible for vital purposes. And that seems to happen when excess body fat starts to accumulate in ectopic sites. And by the ectopic sites, we mean sites other than subcutaneous fat. And principally, we're thinking of liver and pancreas. And it seems that as the fat accumulates in liver and pancreas, so metabolic conditions develop, the metabolic syndrome, including type 2 diabetes. Next slide, please. We've known for many years that type 2 diabetes is much more common in people who are more overweight and more obese. And this is a slide from the Nurses' Health Study, very famous, very old study now. But it makes the point that the relative risk of developing type 2 diabetes, of course, it's very high with a body mass index above 30, but it's also extraordinarily high with a body mass index between 25 and 30 in the orange color here. And it's also elevated to dangerous levels with a body mass index of 23 and 24 at a population level. And we must understand that most type 2 diabetes in the world occurs in people with body mass index below 30. So the peak of populations is still below that level, and seeing the largest numbers of people with type 2 diabetes with a body mass index below 30, particularly in Asian countries, where there is a greater predisposition to type 2 diabetes with a lower body mass index. Next slide, please. The current pattern of diabetes is terrifying. This is a disease which is accounting for almost 10% of entire healthcare budgets in the EU, and which includes the United Kingdom. The increase in cost has been largely because of modern treatments, very expensive modern treatments and drug treatments, and also, of course, the cost of complications of diabetes. And the projections, and this slide shows the projections from 2000 up to 2030, so only 8 years away now, shows how the very high costs in Europe will increase further, but there are much greater proportional increase in costs in other countries, particularly in the South Asian and Indian subcontinent, where the costs of diabetes are already high, and they're going to increase dramatically over the next few years. This is a disease which is shortening lives. It's still shortening lives by 5 or 6 years, which is comparable to a major cancer, several major cancers of that order, despite our modern treatments. The next slide, we went over one. Can we have the next slide, please? Shows the ray of hope that we have introduced with recent research. And this is a summary slide from the DIRECT trial, a study which introduced a weight loss management program for people with type 2 diabetes. In the top panel shows the MRI scanning of their pancreas, and it shows on the left the pancreas of somebody with type 2 diabetes, which is a rather sad, tired, ragged-looking pancreas. Over 2 years in this study, the pancreas gradually filled out to become indistinguishable from the pancreas of normal subjects who never had diabetes, and that's shown in the right-hand side. And below that, for each of these periods over 2 years, with the normal pancreas on the right in the blue column, you can see how the pancreas volume increased, how the pancreas, that raggedness, that ragged border reduced and then how the insulin secretion from the pancreas rose from below half of normal in a patient with type 2 diabetes gradually to reach an entirely normal level. And this is the average, the mean from the entire study over 2 years. This study showed us that a remission of diabetes, reverting to a non-diabetic state, can be achieved by almost 9 out of 10 people with type 2 diabetes if they lose 50 kilograms, 15% of body weight, and that remission of diabetes was associated with a loss of the pancreas fat, with a normalization of the pancreas morphology, and then a return of their insulin secretion capacity. So a functional normality, not just an improvement, but normality was achieved by major weight loss. And that gives us hope for reversing the disease, but it also tells us that this is a preventable disease. It's proof that this is preventable because we can reverse it. And the next slide, please, shows how we now envisage the effect of weight gain causing overweight and then ultimately obesity, if you like the BMI cutoffs. About 60% of all people do not have the genetic background to cause metabolic syndrome. As they gain weight, they will have a modest increase in macrovascular heart disease as they grow older. However, about 40% of all people, and possibly more in Asian countries and Indian subcontinent, if they gain weight, they will start to put fat at an early stage into the liver, the pancreas, into ectopic sites, and they will then develop type 2 diabetes, high blood pressure, and they will have a lot of heart disease, and of course also the microvascular complications of diabetes. And what we've shown in the direct trial recently, if you see the next slide, please, is that we can reverse that process. By weight loss, we can take away the ectopic fat and the secondary consequences of type 2 diabetes and hypertension. And this is really the final proof that this is a totally preventable disease at an earlier stage before the disease develops. So the summary slide, please, next. What we understand now is that type 2 diabetes and obesity develop together. It's been called a syndemic, 2 pandemics together, as populations develop Western lifestyles, and that reveals the genetic tendency for them to gain weight, which is present in about up to 90% of all humans will gain weight if given a high-calorie, highly attractive food diet. We also recognize, interestingly, that the highest prevalences of obesity are in what I've called island states, and that includes small islands, but also in the islands, let's say in the Middle East and in the Gulf states, where the reliance of the population is largely on imported, manufactured, and nutrient-poor foods, which have added value for the manufacturer, but not for the consumer. About 40% of people have this predisposition for genetic reasons to metabolic syndrome and will develop their diabetes together with the excess fat in ectopic sites. And that relates both to insulin resistance and to a suppression, but not a permanent suppression of insulin production from the pancreas. And that is the background to type 2 diabetes. So we've now understood that type 2 diabetes is really part of the same disease process of obesity in people who are particularly susceptible. It's preventable and even reversible in its early stages. Thank you very much indeed.
Thanks to Professor Lin for a very impressive. Thanks to Professor Lin for a very impressive. Thanks to Professor Lin for a very impressive presentation. So we'll move to the second speaker. Our second panelist is Dr. Francos Branca, Director of the WHO Department of Nutrition of Health and Development, who will be talking about obesity and diabetes in the global political agenda. The floor is yours.
Well, thank you very much, Professor Hussein, and let me congratulate the International Diabetes Federation and World Obesity for this policy brief. We in WHO do believe that diabetes and obesity need to be addressed simultaneously. And you've heard some of the reasons. We also would like to remind everybody that diabetes is a key comorbidity for obesity. 1 in 5 deaths really as a result of obesity are accounted for by diabetes. And next slide, please. And you can also see if you can please, yes, thank you, that the rising trends of type 2 diabetes, which have been extremely quick with 70% rise in premature death since 2000 and a projected enormous increase in the decades to come, both in terms of speed and in terms of distribution, and can I have the next slide, please, are completely parallel to the rising trends of obesity. Both are a major roadblock to achieve the Sustainable Development Goal 3.4 of a 30% reduction in mortality for non-communicable diseases. Next slide, please. So this is why obesity and diabetes have been addressed together in the context of the WHO policy work at the latest executive board in last January. We had a comprehensive report to address the progress of the prevention and control of non-communicable diseases, and two documents came in parallel: draft recommendation to strengthen and monitor diabetes responses and draft recommendation for the prevention and management of obesity. Both are connected to an overall implementation plan for the period 2023 to 2030 for the prevention and control and of non-communicable diseases. Specifically, member states asked WHO to develop an acceleration plan acknowledging the poor progress in the achievement of the obesity and diabetes goals. So specifically asking how the WHO would support member states in implementing this recommendation. Next slide, please. These documents also contain more than the common targets of halting obesity and diabetes. They contain operational targets, and that's also a way to focus on some of the policy areas, both in prevention and management. If you look at the obesity targets, we're talking about physical activity, we're talking about early interventions in the diet of a child, breastfeeding, but also we're talking about the need to improve the capacity of primary health care services to diagnose and management of obesity, including an increase in the density of nutrition professionals in the different countries. And in diabetes, it is about having adequate diagnosis, but also having adequate availability of the supply of insulin and other drugs for the management of diabetes. Next slide, please. The action is aligned. In diabetes, we have established a global diabetes compact, and the compact is focusing on, it's a collaboration, it's a large collaboration, but focusing on certain key actions for the prevention and management of diabetes. So for the prevention of diabetes, the decrease in childhood obesity is a critical one. And for the management of diabetes, the early diagnosis and management of obesity in primary health care is also a critical element. Next slide, please. So the acceleration plan is going to acknowledge the fact that, if we want to address obesity, we need to look at multiple systems, not just a health system, but food system, social protection system, sports systems, urban design and built environment, education system, information system, and the digital environment. But we would like to focus on a set of policies that are game changers that, if implemented at scale, could at last bring to the reversing of the epidemic. And this is about fiscal policies, particularly the taxation of sugar-sweetened beverages, policies to regulate marketing and sponsorship of food and drinks, particularly to children, clear front of the pack labeling, standard and regulation for physical activity provision in schools, early food environment, food procurement in public institutions, and integrated obesity service delivery, including diet and physical activity in primary health care. And finally, a service delivery framework, if I can have the next slide, a service delivery framework for obesity and diabetes that aims to provide services in the community and at the different levels of healthcare, primary, secondary, and tertiary, using different entry points of the life course. All this integrated in the NTD packages. So this is going to be really our commitment for the years to come. And next slide, just to thank you for your attention and commitment to this important course.
Thank you very much, Dr. Branca, for that excellent presentation and for the partnership of World Health Organization in this initiative. Our third panelist is Professor Wani Nityanand, who is chair of the Fatless Belly Ties, an initiative by the Royal College of Physicians of Thailand. Dr. Wani?
Hello, everybody. Thank you for opportunity for me to present or share with you the burden of obesity and diabetes in Thailand. In Thailand, we have National Health Examination Survey at interval of 5 to 7 years since 1992. The survey includes questionnaire, simple physical examination, and blood tests. The 6th National Health Survey done in 2019 to 2020, and the report come out last year. The report make into section. The first one was for children and adolescents aged 1 to 14 years, and the second one for adult aged 15 years and above. Next slide. In this slide, no, not this, the previous one. In this slide, the blue line show the prevalence rate of the obesity. For Asia, we use BMI of 25 as a cutoff of obesity. And you can see that in 1992, the prevalence of obesity is about 17%. It steeply rose to 42% in 2020. The last survey said. The yellow line is demonstrate the prevalence of diabetes. And you can see the diabetes also rise along with the BMI, but not at the same rate as BMI. We have about doubling of prevalence of diabetes from 1992 to 2020. That's from 8.9% to 9.5% in 2020. Next slide. This slide demonstrates the result of the 6th National Health Examination Survey in detail. On the x-axis, you can see it's divided into different age groups from 15 to 29 years as the first group on the left, and up to 80 years or more. And you can see that the prevalence of obesity is quite high, even in the youngster. It's about 33%, and it's go up gradually to maximize at the age of 45 to 59, up to 47%. And then it's declined gradually to the low rate of 19% in people who are 80 or more years. And the prevalence rate of this study for all age group is 42%. It's very high. And we also have a prevalence of abdominal obesity. You can see that the pattern is quite similar, but the female in red column compared to male, you can see that the female had fatter than males. And also the overall rate in the whole group is 39%, quite similar or close to what we have for BMI. In the lower panel, on the left, it demonstrates the prevalence of diabetes, which we use fasting plasma glucose of 122 as a cutoff for diabetes. And in young age group, you can also see the initial 1.7% in 15 to 29 years old citizen, and it go up to the maximum at age 60 to 69, and then decline. The average prevalence for this group is 9.5%. Again, you see more diabetes in female compared to male. And the other panel, the lower panel on the right, this is the prevalence of prediabetes. Those who had a fasting plasma glucose from 100 to 125 milligram per deciliter is shown in the light lower panel. This quite different from the diabetes profile. You will see that male had more impaired fasting glucose compared to female, and it goes steady go up from young age to very old age. And the overall prevalence of IFG in Thailand is 10.7%. Next slide. This is what have been done for obesity and diabetes in Thailand. Actually, we start very early in 2006. We faced the problem of metabolic syndrome in Thai citizens, and also the increasing prevalence of diabetes and cardiovascular disease, as well as hypertension and problem with cancer. You can see that the left half section is working on the campaign of obesity, and we try to teach and give the knowledge to public and every set of age group that what is obesity, how is harm, and how it's developed, and how to solve the problem. So we do campaign on the people or public for maybe up to 6 years, and we did not achieve much of a result. I mean, they have pay attention to what we set up, like showcase, seminar, workshop, or festivity at many occasions around the country. But as you see before, the obesity rate is still increasing. And in 2011, when UN announced the global burden of NCD in September, Thailand also accept this problem and bring back to initiate some activities. Our group, I mean the Fatless Belly Thai, start to working on 4x4x4, that is 4 risk factor, 4 biochemical change, and 4 group of non-communicable disease. And we try to do the life course approach. That means joining with OBGYN and pediatric group to take the life course approach for baby, for the pregnant mother, for the baby, for the children, and up to the adult. But the things is going on maybe now and then, and it's not steady going out. This may be because we're working alone. I mean, the health sector is trying to solve the problem, but there is no joint activity from other sector. You see that the second half on the right side, we start to work in multi-sectoral pattern. That means we join with the other sector, the Ministry of Finance, Ministry of Labor, and other else to put more effort in terms of try to reducing obesity and diabetes. We passed the SSB tax, the sugar sweetened beverage tax in 2015, but it's not implemented in that year. It's delayed for 2 years before it start to work in 2017. And we also had the WHO join with the country cooperation working on NCD. In 2018, we had a UN Inter-Asian Task Force come to visit us and talk to the Prime Minister of how the action of NCD going around the world, and also would like to see how Thailand is doing for NCD. And they left and said that they saw the effort of the public health to do it, but the multi-sectoral partnership is something that need to be boosted up. And the Thai FDA had worked and be able to ban trans fat in early July 2018. And also we had the Health Reform Commission for the country, which revised in 2020. And I have opportunity to present NCD to the Health Reform Commission and tell that the problem start very early and affect a lot of working citizens of Thailand. And finally, when they hear all the problem that maybe need to be reformed in terms of public health, they conclude 5 main stream to be done that we call is 5 big rock. Number 1 is management of public health emergency, including national epidemics that we have, like COVID at the present, and emerging disease for health to secure the health of the nation. The second one is enduring health promotion and prevention of non-communicable disease for citizens and for the person or the one who had the disease already, and make a focus on the working group by improving health literacy and lifestyle modification. The third reform will be on health service system for the elderly and for home and community care, improving medical care and self-care in the innovative primary health care system. The fourth one is reform the health insurance system and related fund to ensure the unity, integrity, equity, sufficient and sustainable finance. And the last one, the fifth one, reform each health zone to have a streamlined integrated management service system. Set up joint responsibility for health between health agency and other agency.
Thank you, Dr. Wendy. This is excellent. Excellent presentation.
Thank you.
My colleague, Dr. Hussein, and I will, thank you very much for that. My colleague, Dr. Hussein, and I will now moderate a roundtable discussion with all of the speakers. So there's many questions that have come in and extraordinarily rich presentations that we'll have an opportunity to have greater discussion on now. Akhtar, did you want to say a couple of remarks in terms of it?
Yes, first of all, I would like to say that is this is a very impressive presentation, and this is really showing the kind of unification of our thinking from the WHO to the organizations that are actually implementing at the grassroots level, that is the IDF and both. So, and something is wrong. I don't think that I can get my picture. Even though I'm trying my best, but anyway, so these are remarkable discussions. I see that number of questions that is arising, but we also have a kind of fourth panelist who will be joining, Professor Lin, Professor Dr. Branca, and Professor Nityant in this roundtable. Her name is Hida Koga, and she is a member of the IDF Blue Circle Voices Network from Zimbabwe, who is living with type 2 diabetes. May I ask Ms. Koga to introduce herself? Mr. Koga, Ms. Koga, are you there? Yeah, please.
Yes, thank you very much. My name is Heather Koga. I'm type 2 diabetes since 2012. And I'm a member of the IDF Blue Circle Voices from Zimbabwe.
Yeah, and so that's an interesting. So before we move to the to our panel discussions, should we ask my colleague Johanna to say something about the key takeaways from the IDF both policy briefs? Next slide.
Johanna, your microphone is closed.
Yeah, sorry, we'll have an opportunity to wind up with the key takeaways. I think at the end of this presentation, I think we'll go into the roundtable now if we could, just to move forward on that, because we're a little bit delayed. I think we wanted to hear, based on the fact that we've heard from professionals and yet not a patient. I think we did want to hear, have just a couple of questions from Ms. Koga before taking on board some of the other questions.
Yeah. Then I would like to say that thank you. Thanks for sharing the patient perspective about living with obesity, Ms. Koga, and type 2 diabetes. Did your doctor ever inform you about your increased risk of developing type 2 diabetes when you had higher BMI?
I would say no, because before my diagnosis, I hardly ever visited the doctor. So I think the few times that I did visit, I remember one visit when I was told about the increased chances of getting heart disease. I remember that one particularly, but I don't remember being told about type 2 diabetes.
Did you receive appropriate information on sort of healthy habits or changing diet or anything from your doctor after your initial diagnosis?
Yes, I did receive some information, especially regarding change in diet and other issues like the importance of exercise. And I was referred to a dietitian. So I would say to date, I've visited 3 different dietitians now.
Great.
May I ask Professor Lin that Koga has shared her perspectives as an adult, but type 2 diabetes also affects children. Professor Lin, what is the situation when it comes to type 2 diabetes in children?
You're also muted, Professor Lin.
This is going to be a recurrent problem. Type 2 diabetes in children fortunately is still very uncommon, but the numbers are increasing, and it is very clear that it develops really only in children who are seriously overweight at that age. It's very clearly related to weight. You find that the siblings, if they're not overweight, do not get diabetes. So I think I've no doubt that it's the same disease process. It should respond to weight management, but pediatricians have historically and even now have not put any emphasis on weight management. Even in extremely obese children, they often put them onto drugs which cause further weight gain, including insulin. So I think the strategy for management of adolescent type 2 diabetes needs to be reviewed. There has not yet been a clinical trial to assess the effects of weight loss, but I would expect that it would probably show the same as we found in the direct trial. I expect children have a lot of fat in ectopic sites in liver, in pancreas, and in other internal organs also. It's a tragic situation because the outlook is very poor.
Thank you, Professor Lean. Dr. Branca, what would you say are top 3 priorities you would put forward to address this double epidemic of obesity and diabetes?
Well, we have to work on prevention and on management, and they have to be done simultaneously. On prevention, I would say that we have to act on early food environment, so breastfeeding, promotion, protection, and support. And we have to act on the food environment, early food environment for children. So taxation of sugar sweetened beverages is important, offer of food in public food procurement. And then we need to work on the management. We need to make sure that we offer the services and they have no cost for the customers. And it has to be on the diagnosis and on the management. It has to be simultaneously done at the 3 levels.
Great, thank you very much.
So Professor Nityanth, let's talk about your national initiative in Thailand. What are the ongoing activities of the Fatless Belly in your project currently?
Currently, we're working on the citizen in working office, because we saw in the National Health Survey that the working people, even in the office or in the industrial, they are getting fat at the very early beginning when they start to work. And also maybe at around 40 or 50, they develop diabetes. And according to the survey that we done in the taking care of people with diabetes, this group, I mean the working citizen, had the less good control compared to the other groups. So we target our work on the working people, I mean in the workplace, and we try to tell them or teach them what is NCD, what is diabetes, how to prevent it, and how to change their lifestyle to lessen the problem of getting obese. We see that most of our people had less activity. I mean, they have more sedentary lifetime working in the office, and in some industry, most of the time they sit down and do the work, not move enough to make the body, burn the calories. So this, what are we calling for? Training health leader in the workplace. That means we ask for HR, the human resource person, or the nurse, or people working in the health office or clinic in the industry or workplace to learn more about diabetes, obesity, and NCD, and ask them to taking care of their employee. I mean, in terms of good or better food that they have for their workers, and also space for physical activity. And this is the ongoing, and we hope that maybe in the next few years we can have more workplace that taking care of their employee in terms of prevention of obesity and diabetes. Thank you.
Dr. Wani, that was incredibly, really interesting. And just a couple of comments, or one comment, one question. So you're speaking about a workplace. In many ways, our national policies tend to be about the healthcare setting, but you're speaking about workplaces as being critical settings for interventions and for ongoing management. Is this something that employers are paying for, or is it from the government? And what would be, just related to that, are there other sort of obstacles in implementation aside from the one you've already identified?
Right now is maybe the pilot project, and
Okay.
we are funded by Thai Health Foundation, which they have a syntax, for us to be, spent on this project. But in the future, maybe it have to be the company or the workplace, to pay some of preventive measure like this.
Great.
Professor Mike, so we have learned very interesting things from Thailand, and if let's move other than Thailand to the greater Asia, as you know, that epidemiology predicts a huge increase in type 2 diabetes in lower and middle income countries, as you have rightly said, especially in Asia. But when you said Asia is also very different. East Asia and the Southeast Asia. That, for example, Japan, China compared to India, Pakistan is a different one. Do you think that we require a different strategy for prevention of type 2 diabetes in this population and your remission, knowing that more than 50% of the people in this area are actually not obese?
Yes, I mean, I think it's really important to recognize that type 2 diabetes develops as part of the disease process of obesity, not with a body mass index of 30. So most people with type 2 diabetes are not obese. And that applies in Asia, it applies to South Asia, particularly to the Indian subcontinent, as I'm sure you know, where many people have a much lower body mass index. Now, some of them have other factors behind their diabetes. So, for example, have had a history of pancreatitis, and if there was malnutrition in early life, that can provoke a damage to the pancreas with type 2 or a disease which looks like type 2 diabetes in later life, which is not dominantly caused by obesity. But most people with type 2 diabetes are those who are overweight and who at least have too much body fat for their genetics. They're people who are putting that extra fat into the liver, which malfunctions, into the pancreas, which malfunctions, and that is reversible. So in principle, I think the strategies have to be the same, as Professor Branca has pointed out, to restrict weight gain in whatever way we can, excessive weight gain in whatever way we can. It's more critical in countries where the prevalence is very high, with a high predisposition, and that applies to South Asia, in the Indian subcontinent, but also in China, where very high prevalences are now becoming apparent with lesser degrees of obesity. So I think possibly the primary strategy, the biggest hit, if you like, would be for a move, if this can be done, towards more traditional eating pattern, using foods which are more nutrient replete and less calorie filled, whatever technique. Now, no country has done that yet, and it's really a major task for WHO, for IDF, for World Obesity to try to take this one on, because you have a massive industry which is very, very good at selling more and more food to people who don't appreciate the outcome. One possible solution here is to begin to look at type 2 diabetes and to recognize that its clinical consequences, shortening lives, is really rather similar to many big cancers. And if we look at the comparison, they're not direct comparisons, but you can see figures on the extent to which a disease like breast cancer shortens lives. It's not very different to type 2 diabetes. And we should begin to recognize what a serious disease this is. In South Asia, in particular, there are many people who accept diabetes as a mark of seniority. It happens in across the family, and they've come to accept it and its consequences. And I think that's very tragic. The fact that we're seeing it in young people, as we mentioned, is kind of highlighting this as increasingly a problem which is now having terrible effects on families and on communities. And so, for example, in Nepal, we have a research project which is attempting to put in place a community-owned diabetes prevention and remission program, which really doesn't involve healthcare services. It means a reversal of eating habits towards a more traditional pattern and a greater understanding within communities as to what this disease is doing, and that it is preventable and potentially reversible. So I think we must look outside the box at ways in which we can empower people to take on the obesity epidemic. We have looked at the use of social movements in young people, which have been very, very effective in things like addressing gun law in America, or social change in a whole lot of areas where young people have taken on this target. And I think if young people can take on the consequences of sort of westernized food lifestyles and see value in alternatives, that would be very exciting also.
Thank you, Professor Lean, for your response, and particularly focusing on the role of young people. We've experienced that in multiple ways, that the benefit and our need to support and legitimize their vital role in this area. So thanks very much for those. Those were excellent responses. I have a question now for Professor Branca, but before that, I want to just say one comment on the questions. We are receiving probably more questions than we would be able to answer in the next 20 or so minutes of this panel, although we will do our best to get to as many of them as possible, but we will respond to them. So IDF and WAF will come together. We'll reach out to panelists for those questions that were directed towards you that we were not able to get to today, and we will also provide our own responses, and that will be provided in a post-event mailing alongside the slides and other information, as well as, of course, the policy brief, which is why we're all here today. So I do have a question for Professor Branca, though, and it's one, frankly, that I've posed to him before, which is, first of all, incredibly encouraging how much activity there has been, how much accelerated activity there's been around diabetes and obesity, particularly, frankly, since COVID started, and we all started to very quickly be able to show the rest of the world that having underlying diabetes, underlying obesity, were creating people at much greater risk for complications and death due to COVID, and that continues to be the case. But with, we've had our prevalence targets, not reached them. What is it now with our targets to 2030? What are the key imperatives on the part of WHO, civil society, professional community, and I think patient community, and by that I mean people with lived experience who really have been too often not acknowledged or given enough of a central seat at the table. What are the key imperatives between now and 2030 to reduce the burden and the challenge of obesity and type 2 diabetes, or diabetes in general?
Oh, thanks, John. I mean, I think there's two main points. I mean, first of all, it's the scale of the response. Obesity and diabetes are global challenges. Everybody has them. And the response has been too timid for different reasons: lack of investment, lack of policy commitment, but also, in a sense, a lack of overall consensus about what needs to be done. And even the conversation we're having today in the chat, people are hesitant. Oh, but this policy doesn't work. This doesn't work. This doesn't work. Okay, but first of all, now we have much better understanding of what really works. We have a package of policies which are demonstrated as cost effectiveness to changes for the environment. We have a lot of experience done, particularly in high-income countries, on how to provide those services. We need to implement. We need to, at the moment, certain key policies are implemented probably in 1/3 of the countries. That number has to double. And we need to do it pretty quickly. The coverage of services, very, very poor and limited to high-income countries. That has to change. So I think the scale of the response is the first thing. The other one is about the accountability. I think we need to explain what happens if we don't act. We need to give the numbers, and the two are connected, because we really need a major advocacy effort. And I really here would like to acknowledge the collaboration that we've had with World Obesity Federation and with the International Diabetes Federation on really creating this global movement that pushes policymakers to make the right choices. I think that's what we need now.
Thank you. Akhtar, did you want to respond to that, or did you? No. Okay, so I think we actually believe that. First of all, thank you very much for that, and Akhtar and I have spoken about the role of stigma as well, and I think we wanted to pose a question to, in a way, for all of you to consider this. But
I think in order to understand a disease, I think that we experts think one way, the so-called experts that we are in this global scenario. But in order to understand, we need to understand the patient perspectives. And so therefore, I think that it would be very interesting to know from Ms. Hetra Koga that that people talk about stigma, and I myself, as you know, that I'm a migrant in Europe, and I also live with different stigma compared to your stigma, and as a kind of member of the minority community. So I would be very much interested to know that about the stigma, people living with obesity and type 2 diabetes in your community. What is in your community, I mean that in the community that you live in Zimbabwe, that what is the kind of stigma that you faced and which you found difficult to cope with?
Thank you. Yes, there is indeed a lot of stigma associated with diabetes as well as obesity. Some of it arises from people not understanding what diabetes is all about. They don't understand the causes. So you get some people thinking that maybe if you have diabetes, you have been bewitched or something. There are a lot of myths associated with it. And then you get those who say maybe you were eating a lot of sweets. And then the phrase lifestyle disease also contributes a lot to the stigma because people now see that, people interpret it that you brought it on yourself. So those are some of the issues that arise from being type 2 diabetic and also being obese. You actually have people calling you some nicknames because of that condition.
But do you face any kind of practical problems, for example, in terms of employment, in terms of education, in terms of marriage, etc.?
Not exactly. When I look at employment, I myself am employed. You don't really get gatekeepers when you want to get into employment. But then when you are there, the kind of discrimination that you face is that there are no provisions that are made for you being diabetic. You are just treated like someone else. There is not that understanding that you probably need some accommodations to be made for you in the.
Thank you so much to share your perspective, Johanna.
Great. I actually had a couple more questions. I think I can also direct them at Dr. Wani, for example, around stigma, because I think one point that we've seen in the chat and that we've seen quite a bit is that also there's in some places that being at a higher weight is a sign of status, of wealth, of not having an infectious disease. And indeed, in some places, there's, sort of a woman to be marriage material needs to be, to be big, and that is in some ways one of the other challenges, and that's where framing obesity in particular around the health issues associated with it is really important, so that there's not a judgment about size, but just about health implications. But I wondered in the Thai context, Dr. Wani, do you see stigma playing a role? And I'm going to ask a slightly tricky question about that too, is do you think that sort of bias against diabetes, against obesity based on not understanding it, even play a role in both not receiving adequate political priority? Do you think that has any part to play? I know it's a very difficult, subjective question, but I'd love to hear your response to that.
I don't think Thai people, concern much about the stigma of being obese, or even they have diabetes. But it's a culture, maybe, you know, old culture fashion, that the wealth is shown by, you know, how fat you are, and especially when you have a little belly, you know, it means that you in good economy, and maybe, you know, so it look good for old fashion, like in Thailand. And also the grandparent and also father and mother of the children, they think that the obese children is cute, and if you don't have cute obese children, maybe is maybe, you know, to be blamed that you don't feed them enough, something like that. So right now we try to raise awareness for this, you know, belief that it's not true that being obese is showing the wealth or the good good grown up children. And I think the stigma sometimes, if you don't talk about their body size, they're not concerned. But once you mention, that's sometimes they, you know, they shy, they don't want you to talk about it, something like that. And even though they know that the way they eat or how they live is things that cause the obesity, but they cannot change what have been, you know, their habit. I mean, they like to drink sugar sweetened drink, and they still drink it, even though we tell or they learn how bad it is. So it's difficult to change the lifestyle, I think, for the present people. I mean, the people in this environment, because you have plenty of food and high or dense calorie food, and it's a very thing. I mean, it's a high promotion in terms of sale or marketing. So people enjoy eating and living with an environment that they don't have to move much. You know, they use the mobile, they use the equipment that don't have to go up to turn on the refrigerator, turn on the light or turn on something. Everything is in hand.
Thank you. Thank you very much. And let's go back to Ms. Heather again. And you know that I'm fascinated with your country, Ms. Heather, that Zimbabwe. Actually, I worked in Zimbabwe. I worked in Tanzania, so I know a little bit about the African situation. But do you think that your government actually could intervene in order to prevent the obesity and diabetes? Or do you think they're doing enough? Or do you think that there is a kind of scope that you, as a member of the IDF Blue Circle, or somehow that we could influence your government to take more actions? Ms. Heather, are you there?
She seems to have dropped off, I think. I don't see her name here.
Okay.
Unfortunately. Okay.
Yeah. So Johanna, so it's your last.
Sure, thank you. And thank you for pronouncing my name in a Norwegian way. So Scandinavian solidarity here. I have a question for Francesco, and it came up really in the chat. There was a comment from Tobago around taxing sugar sweetened beverages is helpful, but not sufficient is probably the way I would reframe it. And wondering more broadly, I think just because of the kind of the population of Tobago, perhaps even the tax base, I'm not sure, but how do you envision integration of obesity and diabetes response in countries across the life course? And maybe responding both to the sugar sweetened beverage question, but then to other approaches. How would you see this working?
No, thank you. And I was going to reply actually in writing to Adelia, who asked a question about Trinidad. Yeah, I mean, definitely we need to understand what is the situation in each country. So roadmaps by countries are useful, are important. you will see that most of the patterns are similar, particularly when we have, similar countries, such as in the Caribbean or island countries. There are common elements, so we can build on that. Now, changing food environment and changing the food system is a big deal. There's enormous commercial interest, and so establishing those policies will require really mobilization of civil society, academia, and major political commitment there. So that is important. Taxation on its own is insufficient. Taxation is important to reduce the consumption of sugar sweetened beverages. It depends on how it's done, but if it's done by the book, it works extremely well, but it's insufficient on its own. So we need to have some package of policies for the improvement of food environment. So we need to have, good marketing policies, for example. We need to have school food offers. We need to have water in schools, water fountains in schools. This package of changing, particularly the early food environment, is something that we need to do. So that's an important one. Now, how can we create that continuity to prevent both diabetes and obesity? Well, the changes in the environment are a common agenda. And we should mention even more the importance of physical activity in schools, and it really as something that should come in our everyday life with a good support from the institutions we work in, whether it's a workplace or whether it's schools. But then really that continuity in the prevention and management should come in primary healthcare services. That's absolutely critical. I was sitting in another conference with World Obesity Federation the other day, and there was a very important point. I mean, if you are relying only on certain measures of the impairment of glucose tolerance in diabetes clinics, what can you expect? Of course, people will have impaired glucose tolerance. You should that earlier. You should do that in primary care, or you should that in obesity clinics. And so that creating that continuity of care, whereas where we look at the risk of diabetes much earlier in the life course of that disease, as Professor Lin was explaining. I mean, something should happen early enough, and early enough in terms of life course, and early enough in terms of the origin of the disease, and understanding that particular individual has a high risk, it's a much higher risk to progress to diabetes. That's when we need to intervene. So I think that continuity isn't there. We have partitions in the health systems, and we need to create that greater continuity and really planning over the life course of an individual.
Great, and I think so very much that's about an integrated and holistic response, which is something that we very much need to see. I think I have another question that's kind of come up in a couple of different ways on the chat and through the Q&A, and I know that Akhtar also has a couple of points he wanted to make. First of all, Heather is back. So Akhtar, did you want to speak to her a little bit more, or I think you had another question for her?
If we have the time, so I would like to ask her the same question that we did. Heather, that I said that having given I have worked in your country, Zimbabwe, and it's a beautiful country. Even though I'm not talking about the political system, this has been, and I have also worked in your neighboring country in Tanzania. So I said that the government policies related to the obesity and diabetes, do you think it's enough, or you think that as a member of the IDF Blue Circle, that you, with your group, could persuade your government, or for example, organizations like IDF, World Obesity Federation, WHO, they could come back and could do, so that what are the ways that you see that your government could be more committed to the cause of obesity and diabetes?
Looks like she might, Heather? Looks like she might still be frozen. Heather, could you turn off your screen maybe? Would that work?
Thank you. Hello.
Yeah.
Can you hear me now?
See.
Hello.
Yes.
Yes. Yes. I was saying I would urge our government to provide more education and awareness on the conditions on both diabetes and on obesity, so that people know what it's all about. How do we prevent? How do we manage the conditions? Encourage things like healthy eating, encourage exercise, encourage access to specialists, diabetes specialists, and encourage the production and discourage actually the production and consumption of unhealthy foods like processed foods, fizzy drinks, and so on. Maybe they could tax the production and sale of such foods. And then just give more attention to diabetes as well as obesity, because we've seen that with the coming in of the COVID-19, attention has been sort of taken away from other conditions. And it looks like COVID-19 is getting the bigger share of the attention.
Okay, thank you. Thank you very much. And Johanna, would you like to go to this to the questions in the question and answer box, or
I think we have time for probably just one more question, and it's around I think it's around actually language and images. So back to the stigma point. So we've been hearing a few different things around this, around how obesity and diabetes are seen and portrayed. We know that they're misleading imagery. We know, as we heard, even much T2 diabetes occurs in sub BMI of 30, and yet the imagery of obesity tends to portray, almost make it seem as if 40 to 50 BMI is the norm, and then with lots of sort of photographs of imagery of people gorging on unhealthy foods. We know that's mostly out of individuals' control, what's even available to them. I think this is more just a question. Perhaps Professor Lean, I'd ask you to say, how can we find a balance so that we have non-stigmatizing language and imagery, but that we also recognize cultural differences, recognize some of the nuances, recognize that foods, ultra processed food definitely is playing a role, but that in fact the agency for access to it is often out of the individual's hands.
Yeah, I mean, there have been several questions here which have been asking about the psychology behind weight gain, the psychology behind our understanding of what this disease is. And I think there's been a lot of mystery and misunderstanding, and the need for education has been mentioned by several of us. So I think education at a very young level to teach children what these diseases are and how they're coming about. Now that we really have a very full understanding of the disease process, how diabetes follows obesity, and the fact that this is a serious disease, we teach children what a cancer is. We should teach them what diabetes is. And I come back to this idea that I think obesity and type 2 diabetes are disease processes which are now sort of collateral damage from successful social marketing of food. I mean, when I was a young person, we never ate between meals. We would be punished if we ate between meals. Meals were sacrosanct. Now we give all our children snacks in order to have extra calories between meals. It's no small wonder that this marketing has been successful. It's attractive. They like the taste. And I think we should try and invoke the power of young people and their collective psychology to tackle this problem. The young people have reacted against smoking because they see they're being exploited by industry. And I think there is a parallel. Of course, it's not the same. Food is not tobacco. There's nothing, it's not poisonous. But the exploitation of all people, not just young people, is happening. And we see it tragically in the developing countries, in lower and middle income countries now, with rapidly increasing rates of diabetes secondary to their weight gain. There is exploitation there. Somebody's making profit from that. Young people have the power, the strength, and the collective psychology to take this on. And I see that as the untapped resource across our globe.
Great, thank you. I think that wraps up the panel section. We're going to just go into some summary remarks now, but I want to, Akhtar, did you want to say a few words?
Yeah, I would like to say that it's very, very interesting, and for me as well, particularly Professor Lean and Branca and Nijant, and also my colleague Koga from Zimbabwe. And I think we have learned a lot. But I think that it's my conviction to say that, for example, we, the so-called experts, should be able to see that we do not know everything, and we cannot give answer to all questions. We are in the process of learning. For example, as we know that, for example, type 2 is not type 2. Now we are coming up subcategories of type 2. So we have to say that there will be new things coming in. We know it's not that we don't know anything. It's not that when we are saying that we should be having a role of learners, not necessarily always a teacher's role. And that is something that when we always go in the role of a teacher to the community, because you see that my background, that coming from a poor country, I'm originally from Bangladesh, living almost all my life in Norway and the US. I have also taken my education from Boston University. So we see that, for example, people see that somebody is coming from the sky and telling us what to do, and we feel that they do not understand what we are actually, the context of it. So I think that we need global cooperation. We need also to take the role, sit back and listen to the people and try to see that, okay, there are things that we actually do not know. As for example, we have seen that, for example, in one of the publications that I made, I have said that, for example, the so-called marginalized diabetes that I sometimes call lean diabetes or marginalized diabetes, BMI less than 23. If they lose their body weight, they will actually increase the risk for type 2 diabetes. So there are many things that we still are learning in the learning process. But having said it, I think I have learned a lot, and and I see that it's really powerful. And I, on behalf of the IDF, I'll do everything to reach out to collaborate with everyone. For example, BOF is one example. WHO, we are collaborating, as you know, that with the global compact, etc. So anything that we'd like to, I think collaboration, the global cooperation, and to take a step back to the position of a learner and to say that how we can jointly work together, not that I'm teaching you, but we are doing and work together. So I think that would be the best approach to move forward. And but I'm not saying, I'm not, please do not say that, do not misunderstand. I think I've learned a lot, and I think all these things that you have said is, I think that is to see that, for example, we have more than 600 people on live, which is amazing, and we have lots of questions. Thanks to all those who organized it, and on behalf of the IDF, I thank every speakers to participate on this occasion.
Now, I think we just have one more slide talking about the policy brief itself, just to remember. But thank you to all of our speakers today, because you were really bringing in such great and complementary perspectives, and very much this is about collaboration. I also want to, could we go to the, okay, great. Could we go to the one before? Yeah. So I think some of the key takeaways here are that sort of the roots of obesity is something we put together, and this would really help answer the question, what needs to be done? I think we both, type 2 diabetes and obesity are both diseases that suffer from a desire for people to oversimplify the response and to say, well, just eat less, move more, stop. And we know that the drivers of obesity, which I think are many of which overlap with the drivers of type 2 diabetes, are much more complex than that, and they range from things like mental health, maternal health, and access to healthcare, to aggressive marketing. Particularly, we see that in small island developing states, basic biology, and broader genetic risk, and again, to exposure to ultra processed foods is certainly one of them, but very much not the only one. So these are just I think that roots image, all roots going into one word or one tree is really important as we make sure we never sort of emphasize just one or two silos when we need to have multiple sectors working together. So again, multiple sector is key, and implementing packages of policies that consider external factors. We do believe recognizing obesity as a disease is an important part of this, because it has still suffers from this misperception that it's again just a very simplified narrative. Type 2 diabetes can only be prevented really if obesity is also prioritized. And we need to advocate for people-centered care. I think I want to really thank Heather for joining today and say, I'm your sister in NCDs. I've lived with multiple sclerosis for 30 years and I'm a cancer survivor and doing well today because I had absolute privilege and access, and but certainly been exposed to stigma and other elements. And I think that really remembering not just it's a nice to have or but in fact people who live with diabetes, people who live with obesity have an expertise that, as Akbar said, we have much to learn from, and that must inform our policies and our work going forward. Next slide.
Yeah.
So again, go ahead.
I think probably this is this. I will say that you see that the takeaways from IDF, both policy briefs, that the policy briefs we have just launched, that the national plans must include actions that address obesity and diabetes related inequalities and stigma. And this is a real challenge. I said that I had the opportunity to work, as I said, that I'm originally from South Asia, but I've also worked in China. I've also worked in India, Pakistan. So I've also worked in Africa. I have a professorship actually in Brazil. So I have seen parts of the world, and I see that, for example, those people those who implemented these ideas, I think that there is a kind of big barricade, and we need to see that how the administration could be equally interested and participating in fighting inequalities, stigma. And more, as we all know that, for example, at data collection, particularly as you know that we produce an IDF global atlas, and we always struggle in order to get that kind of national level proper data. And this is I know that WHO is doing now. They are also asking the governments to have the kind of data collection, because this data collection is really important for our all policy makeups. And we need political leadership and engagement to address the environment and underlying social determinants of health. And you see that this is that we people that we. But you see that the WHO is very important in this regard, because we as IDF both we are respected international NGOs, but the government doesn't necessarily listen to the NGOs. They listen to the WHO, and this is the fact on the ground. And so I think that collaboration with the WHO is very important in order to have the political leadership and political commitments in that country, because our health policies coming from a poor country again, that we know these policies are not independent. This is very much dependent on the donors, and WHO is the focal point in that sense. That overweight treatment and prevention to be included as a part of the universal healthcare system, and which is very, very important. But here, as you know, that we have discussed that it has not only kind of medical issue, it is also a very cultural issue. In some cultures, that a certain amount of obesity is seen to be a kind of good health, and also to be an attractive woman. Sorry, not to be a. So we are addressing an issue. It is not any kind of disease issue. It is also very much of a cultural issue. When you're talking about food, we are talking about exercise. We are talking about fatness as beauty, and fatness as a disease is two different things. And this is something that we need to understand, that we are addressing very complex issue. And in this fight, if we have to win, that we need to work together. So it's not that, and together it's not that we are working from the kind of big organizations. We are working together with our collaborators, with our partners in all societies. So that is very important thing for us to see.
So I think we just we just want to say at this point, thank you. Thank you. Thank you. I think that you've received the information on the policy brief, where to download that, how to find that, and also a promise that we will be both responding to questions and providing the materials presented today to all of you who attended. And again, 621 and a significantly larger group that is going to be watching this recording. And so we're really excited about the enthusiasm and proud of the partnership that International Diabetes Federation and World Obesity Federation have. And we know that that is going to only strengthen and grow as we work together in the coming years. So yeah.
But I will also take the opportunity to welcome you all to the IDF World Congress in 2022, and which will provide a kind of unique forum of knowledge exchange. And I know many of you are already invited there as speakers, and this will bring together the extensive global network of physicians, scientists, nurses, educators, other health professionals, government officials, policymakers, media, and diabetes associations that IDF represents globally. As you know, that IDF is operative in 170 countries with 230 organizations. But you also know that this is the first time that IDF Congress will be hybrid. That is a hybrid organization, and delegates will have the possibility to join online, and registration is open to this website that is there, Johanna, and you also have your Congress that is coming up this year.
We have our Congress in Melbourne, Australia in October this year. And again, so you can all first register for the ICO Congress and then for IDF so that we can continue this cross-fertilization. And we really appreciate the enormous interest and help and participation in today's events. So thank you very much. As we say in Sweden and Norway, tusen tack, tack så mycket. Merci. Gracias. You're welcome to say it in Thai if you'd like, Professor Wani. Thank you so much.
สวัสดีค่ะ
Sadika, yeah, I know that's Sadika. Thank you. In Bengali, it's Dhanyavad, and but also tak, as you have said, that in Norway we said tak so tusen tak. So there are ikke så tak so mycket. Some that you say in Sweden we say tusen tak. And it is a pleasure to see you all, to listen to you, and see that how every day we can enrich our knowledge, but with collaboration, with being listening to the others.
Great. Thank you very much indeed.
Yeah.
Thank you very much. Bye-bye.
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 Thank you. Thank you.
Bye-bye. Bye-bye.
Bye. Thank you.